on the work of our community pharmacy colleagues. Sandie, are you there?
I am. Hello, Mudcan.
Over to you.
Thank you, firstly, for asking me to come and speak today. I'm going to give you a very whistle-stop tour of community pharmacy, and happy to pick up any questions afterwards. And if anybody wanted to contact me individually, that would be great. I'm Sandie Keall, and I'm Chief Officer of Tees Local Pharmaceutical Committee. I also feed in as our regional lead for COVID, and I'm part of a national task and finish group for COVID and community pharmacy. So I've been about a little bit during COVID. So hopefully I can give you a flavour of what's happening nationally as well as locally. So just want to quickly run through where we came from, the impact of COVID on community pharmacy, our new ways of working, the ongoing challenge and the potential in community pharmacy. I want this presentation to be very positive and not a whinge, as many could have out there. So next slide, Mudcan, please. So where we started, we moved a little while ago, 2017, to from a volume-based model of dispensing to a service-driven model. So we're very much moving the goalposts in community pharmacy, if you like, to become more of a face-to-face clinical offering. And that was the plan moving into the 5-year plan of our new contract. Our funding streams were restructured along that route, with new quality monitoring and targets that complemented that new plan. In some areas, we were looking at reduced staffing numbers, reduced numbers of pharmacies. So you may have seen 3 or 4 community pharmacies on a high street, and the plan was to consolidate them and make them more focused in what we delivered. And there was an increase in the distance model of pharmacy. Hub and spoke is something that many people have heard of, and it does have its place in some areas. But we still have that value, that complementary service, which needs that face-to-face delivery within community pharmacy. Based on the earlier discussions we've heard there about the PS Home study, one of the questions we had there was around deliveries. Community pharmacy have delivered medicines over many years. This is not a paid service. It's not included within the terms of service, and nor are Medipacks. So where many people thought they were services that we did at a fee, we didn't. Those services were complementary and came at a cost to community pharmacy, many of which within our new funding structure could no longer sustain that model. Next slide. So the impact of COVID-19 was instant in community pharmacy. We have had many regulatory changes, often at very, very short notice. Some of them daily. So what would happen on a Monday was very different to what happened on a Tuesday. Quite often, a lot of our changes would occur and the public would know before we did, as happened in a lot of healthcare. We had a huge shift within what we were doing. Can we just go back a slide? There's a slide missing there, Mudcan. Right, here we go. So, yeah, there was unprecedented demand on prescription services. So some pharmacies saw a 400% increase in prescriptions that were to be delivered within the pharmacy setting, be dispensed. There were lots of changes to prescription duration to prevent patients having to recontact healthcare services, which were already under pressure. There was a change to supervised methadone and buprenorphine within community. So again, it was to keep those chaotic patients out of the health system. So some people moved from a daily supervision to a fortnightly, which again needed to be risk assessed. There were a closure of many other healthcare settings. It wasn't just that GPs worked remotely, but it was also that dentists closed, opticians closed, and there was actually additional pressure on prescription services because of that. Also, a lot of our outpatients departments were focused on redeploying staff to COVID areas, which again reduced the potential of outpatient services to patients. And all of that came back to community pharmacy. Patients were told to shield, Before we had a shielding delivery service, they were told to shield. We had closure of consultation spaces within pharmacy, staffing issues, testing issues, PPE, which is across the board. Medicine supply issues we've already heard about, so I won't go over that again. And we also had hot sites. Quite often a hot site, which is a COVID symptomatic patient to be seen by a medical practitioner, would be co-located with a community pharmacy, which then put that community pharmacy also at risk, and they needed additional PPE and other restrictive measures put in place. Next one. So the regulatory changes I've already mentioned. Electronic repeat dispensing, so GPs setting up systems where a 6-month script in effect would be for a stable patient could be sent to a community pharmacy for dispensing on a monthly basis increased. We had close working relationships with our supervision teams, our sexual health teams, our public health teams in order to continue to deliver services as best we could. We had an increase in CPCS referrals, and CPCS is an NHS 111 service where a patient with a low acuity medical condition can be referred directly to a community pharmacy for a consultation and potential intervention. That service changed slightly, so anybody who had a COVID symptom was filtered into a different stream. We had shared agreements between our pharmacies, although they are all quite often different owners and different organisations. They do have some shared agreements in order to ensure that should one site have to close because of COVID, either because staff had been impacted by COVID or had to shield, etc., there could be a sharing of staff to keep us open. And within Tees, we had no pharmacy that closed during the COVID lockdown. Testing remains an issue. PPE, we have screens now in place, and sourcing of our PPE, actually a lot of which came from outside of the NHS. So we had tattoo parlours, gyms, hairdressers, etc., providing PPE for us. Because there was a national shortage. Medicine supply, and we've worked very closely with our GPs on recommending alternatives where there are medicine shortages, and that has a potential of continuing as we move into Brexit, that other hot topic. And we had some very good synergistic working across our hot sites to ensure that everybody worked safely and succinctly. Next slide. So, new ways of working. A lot of our pharmacies don't have the opportunity of video consultations, but some do, and we're increasing that offer. That is moving ahead at pace, as are our telephone consultations. CPCS is moving forward within the GP remit, so ensuring that GPs can also refer low acuity medical conditions to community pharmacy. There will be other expansions in the future. We've got more service drivers, and I won't go into them now. Flu vaccines has been a hot topic recently, and we're working very closely with our surgeries and CCGs on that. We've looked at waste returns, which when you are receiving hot medicines from a COVID hot site, then we need to have some sort of way of ensuring that that is quarantined until it is safe to dispose of. We're looking at more digitalisation and PCN drivers, as we've heard earlier from a colleague, so I won't go into them. Our deliveries have been done through national volunteer services, but again, that comes with a challenge because you have to ensure you are not giving medicines to anybody because medicines have the potential of harm. So we're looking at how that can move forward. Next slide. So very quickly, the ongoing challenge, regulation restrictions, and we heard from Simon earlier, looking at that happening at pace. We're looking at many training requirements, and we're continuing to train our staff as best we can. Staffing, we've had a lot of staff move to hospital, move to PCNs, move to the care home teams. So it's how do we maintain that quality within our network? Funding will always be an issue across the NHS, and community pharmacy are no different. The expectation of patients, where during lockdown we had the clap on a Thursday, we had patients very grateful for what could be delivered. That is now waning. People are in lockdown lethargy now. People are struggling, and quite often it's the people on the front line who are facing the brunt of that. And it's not just community pharmacy, it's anybody on the front line. We've got healthcare challenges and changes that continue. We have confined spaces for our consultation rooms, so it's how can we use them safely. Move forward. And so my last slide, just to summarise, we're looking at greater use of electronic prescribing and that potential for dental and other areas using electronic prescribing, including hospital outpatients. We're looking at pharmacist prescribers. We're looking at long-term condition management across the piece. We're looking at pill checks, rapid starts, other sexual health services when a lot of sexual health services are now reduced. We're looking at a broader service model to provide referral to other parties from community pharmacy as the frontline and gateway to the NHS. What I would say is, and a plea to National, is the second wave is very different. In the first wave, we ran on adrenaline. We ran on something new. We ran on keeping safe. In the second wave, across the whole of the healthcare system, we're dealing with COVID, but we're also dealing with everything else. So there is a plea that actually we need some comms out there to the public, and we need to continually work together as a network in order that we can provide quality, safe services to our customers and ensure the safety of our teams. We need to look after the mental health of our teams, and we need to do that in a very joined up approach. And that is me.
Thank you so much, Sandie. Very clear summary on what we need to focus on. And thank you, Sandie, for coordinating the questions for when we come to Q&A at the end of the session. It's my pleasure next to welcome Dr. Catherine Duggan, who's the Chief Executive Officer of the International Pharmaceutical Federation next. And Catherine is hoping to share with us some examples from pharmacy and how pharmacy has been affected across the globe with the pandemic. Welcome, Catherine.
Thank you so much, Mojgan. Thank you, everybody. Can I just check that you can all hear me?
Yes.
Perfect, great. So I'm going to try and keep to time. So I will skip through these slides exactly as the other presenters have. If you could go back to the slide before. I just wanted to tell a little bit to colleagues here. I'm a pharmacist known to many on the call and known to many of my colleagues who have presented before me. So I'm delighted to be able to present today. I am Chief Executive Officer of the International Pharmaceutical Federation, which is based in The Hague. It is a non-governmental organisation in official relations with the World Health Organization since 1948. And we signed a specific memorandum of understanding with WHO last year, pertaining to matters around workforce, medicine safety, and issues around access to medicines and supply chains. Next slide, please. The problem and the FIP response to the problem at the beginning of this year was following the WHO declaration of the outbreak as a public health emergency of international concern at the end of Jan. We needed to respond to provide support, guidance, networks, events, and advocacy. I may mention, colleagues, that we have more than 150 national member organisations, more than 170 academic institutional members, and we have scientific member organisations and about 4,000 individual members. So there was a lot to share and a lot to support. So we set up a task force immediately to develop emergency guidelines to support the workforce wherever they worked. And the guidelines have been updated 3 times since. And I think that's something that we all note, that this is not a one-off event. This requires us to update and learn as we go, which is it's quite a demanding skill set. The task force included representatives from all practice settings, including hospital pharmacy. I mentioned that here because community pharmacy has just remained the gateway throughout all of this to primary healthcare. The guidance is available in 15 languages and includes clinical information and treatment, guidelines for pharmacists and the pharmacy workforce, frequently asked questions and myth busting, which has proved to be hugely important, COVID-19 additional resources and summary guidance sheets for specific areas of work. We also developed a dedicated web page and a resource centre. Next slide, please. There's a picture of the web page, and you can see people can have a fast click. This is not just a member resource, this is open access. So creating some information for patients and the public in different languages has also been really valuable as well. Next slide, please. We also knew at FIP we had planned 2 regional conferences in Southeast Asia and in Africa. We had a global congress on science planned for Montreal in May, and a global congress in Seville. These were not going to happen at various points in the year. We had to make decisions to postpone and cancel various ones of them. But in addition, we knew that the COVID guidance we were producing required some kind of digital support. So we set up a program of digital events called Responding to the Pandemic Together. We set up an online platform on Facebook for pharmacists and also pharmaceutical scientists to discuss and exchange queries and experiences, with more than 30,000 pharmacists accessing this. And a repository of valuable resources developed by our member organisations and allied partners. We also issued statements and scientific, technical or professional positions on various issues, which I will come to in a short while. I mentioned earlier on the things that we had to adapt during the year. Our global congresses, for example, we ran our virtual event over a 2-week period, preceded by business events held online. That culminated in World Pharmacist Day on the 25th of September, and we'd extended that into World Pharmacy Week, where we could celebrate what the profession had done, and also, quite soberingly, recognise those who had lost their lives to COVID in the profession as well. Our programme of engagement, therefore, has had to change very, very rapidly. And I don't know that we will lose all of that as we move into any kind of post-COVID world, plus the fact we don't know quite when that will be. But we kept to the fact that we had points in time where we delivered and launched various items and programmes and publications. Next slide, please. Some points then, very quickly. Advocacy. We advocated to governments and international organisations for the role, the safety and appropriate recognition of pharmacists, pharmaceutical scientists and educators. We issued a call to action to support pharmacists and pharmacy workers on the front line, including 23 urgent measures that governments and other stakeholders must put in place in order to ensure the continuity of pharmaceutical care. We've heard that really from previous speakers talking about supply chains and the fact that people still needed their usual medicines, even though there was a pandemic going on, and that pharmacies remained open during this time. So this was really, really important for us. Next slide, please. Some of the measures included that pharmacists and pharmacy staff are recognised as key health workers, and that there would be appropriate resources put in place, including access to PPE. Pharmacy staff are included in the groups of healthcare and essential workers to be tested for COVID-19, and medicines at risk of shortage are identified and mitigation plans put in place. We also pushed for continued education, infectious diseases and emergency response being funded. We also included a statement of principle on the impact of COVID-19 on health equity and vulnerable populations and patients, and this was really important. Community pharmacies, actually I must say, colleagues, that we issued a joint statement with the World Health Professions Alliance in addition, which really raised the profile of pharmacy amongst all health professions as stepping up and stepping into the space. And I think the examples you've heard before from the previous presenters have really showcased how pharmacists have stood shoulder to shoulder with the other health professions, but also how other health professions have stepped in as well. So everybody's playing their part in this. A little bit of showcasing to be done, because in many countries, community pharmacy in particular, because it is classified perhaps as more retail, may not be recognised. But they represent the first point of contact within the health system for many communities. They play an important educational role. We really found that pharmacists had to provide a lot of advice to their patients and the public, and this advice could be changing on a daily basis. In many countries, pharmacists partnered with the government to ensure optimal supplies of face masks, and in several African countries, We had examples of roles played by pharmacists, such as educating populations on safety, infection prevention recommendations. They were regarded as community health leaders in their local communities, and they were accessible for advice. Next slide, please. In the face of shortages, the pharmacists that we have engaged with were also called upon to participate to ensure adequate supply, not just of medicines, but of health products and devices. And studies have evaluated, for example, among Egyptian community pharmacists, the majority of respondents reported high rates of PPE and medicine provision and mass distribution. So we saw the same issues across all of our regions and countries, but we saw them with different amplifications. We've also had examples of the US and Brazil. Hospital pharmacies and pharmacists have played a crucial role during the pandemic to ensure adequate storage and supply of appropriate stocks of medicines and other medicinal products and devices, really getting into the details of provision of thermometers, goggles, and other necessary equipment, ensuring these products are adequately supplied by the hospital pharmacy, and collaborating with other health professionals. Next slide, please. We also saw examples and have examples on our website, which everybody can access, promoting hospital prevention and infection control, informing and counselling, and ensuring the responsible use of the pharmaceutical products. The pharmacovigilance and monitoring really accelerated during this time. And I have to say that in the early stages, when we found countries at different points in the pandemic, for example, colleagues in Italy were able to showcase and share once their crisis had abated somewhat with colleagues who were just entering their crisis. So this was very, very helpful. Next slide, please.
You've got 1 more minute, Catherine.
That's perfect. We saw lots of publications around this, and I have to say some of our colleagues really pushed their publications out. Next slide. You can see the slides. I don't need to read these for you. And also at the forefront of the outbreak, our colleagues in China formulated and launched a series of emergency plans to help us with guidelines. And they developed a pharmaceutical framework for hospitalized patients. That's on the next slide, actually. And it's a schema, which of course may be very familiar to us in the UK, but this was really important because they'd learned from the hospitalized patients confirmed with COVID about how to manage them and then how to adapt this for other patients. Next slide, please. Again, another publication around the drug supply and pharmaceutical care management so that others could learn from it. Next slide, please. And then some examples from our educators in pharmacy. A very speedy rapid response survey was issued, and we compiled innovative case studies from this survey, published in a journal called Pharmacy Education. And this was available for others to learn from. So our academic institutions could support each other through this time. Next slide, please. We had 371 valid responses from universities providing pharmacy initial education and training programs. This is particularly important when we think about the workforce, and we know that even in the UK, we're struggling with the registration of newly qualified pharmacists and getting them on the register so they can fill the gaps. We had responses from 63 countries in this regard. Next slide, please. The wider research urgencies in education included outreach to more regions, including low to middle income nations, continuing the upward trend in IT and digital evaluations, and how are we going to blend experiential learning, which requires these juniors and students on the wards or in shadowing roles, when those pharmacists may need to be shielded or may need to be focusing on their urgent tasks. Next slide, please. Conclusions. The pandemic has highlighted the importance of community hospital. In some countries, we have pharmacists who are called clinical biology pharmacists to ensure continuity of supply. Medical devices is super important in this area, and also their optimal use. After the pandemic, whenever that will be, colleagues, it is paramount that the services we deliver and the value that they contributed are maintained. And we're working with our countries to engage with their health ministries to make sure that any investment or any regulatory changes are maintained after the pandemic, and that lessons can be learned and shared across academia in similar ways during the pandemic. That was super important. For FIP to be flexible and adaptable enough to move to a digital and virtual set of provision has been hugely important to remain relevant, important and essential to our global network. Next slide, please. Thank you for your attention.
Fabulous. Thank you so much, Catherine. So much information you've compiled in 10 minutes. Really grateful to you, and apologies for rushing the sessions. So next up, we are going to play the video, and I may need Pip's help in showing this video. I'm going to try and see whether it's available on YouTube. So I'm going to try and see whether I can share that with you. Oh, here we are.
You have a go, because I think I'm in the background. So you give it a whirl.
Yeah. So this video is from Dr. Tara Rampal, Clinical Director for PREHAB, and her fabulous team of allied healthcare professionals. So we've talked a lot about COVID and how we've been managing it. But this video is a nice addition in terms of how are we looking after cancer patients who've been waiting for treatment. So I'll let you watch the video first, and then we'll move on to questions. Is Tara online?
Good morning. Thank you very much to the NHS Fab Academy for giving Kent and Medway PREHAB project team an opportunity to present our work, the challenges we faced in response to COVID-19 pandemic, and how we've risen to those challenges. My name is Tara Rampal. I am the Clinical Director of Kent and Medway PREHAB, and I shall request the rest of the team to introduce themselves.
I'm Claire Mallett, and I'm the Programme Lead for Living with and Beyond Cancer, or Personalised Care and Support with Kent and Medway Cancer Alliance.
I'm Alison Weller. I'm one of the counsellors providing therapeutic support.
I'm Chris Ford. I'm a project manager in Medway Council in the Public Health Directorate.
Hi, I'm James. I'm the physical activity instructor specialising in PREHAB, working with public health in Medway Council.
Thank you. So Kent and Medway PREHAB is a multi-pronged program which is for optimization of functional capacity, nutritional intake, and emotional resilience of patients before, during, and after their cancer treatment. This project was started as a pilot project in Kent and Medway NHS Foundation Trust. We launched the service in 2018, and it was a hugely successful pilot, resulting in nominations for us being finalists in HSJ awards and winning the Perioperative Care Success Pathway Award and visits from Secretary of State for Health. We also published the importance of prehabilitation and population health and the impact of patients who suffered from cancer but had other metabolic diseases such as diabetes, who received very positive outcome from them. We have our own patient steering group, and we use their guidance and direction for defining how the service progresses. As we were thinking on how to increase the geographical access of our service from a hospital-based pilot to community sites, we were struck by an uninvited guest in the form of COVID-19. The access of patients who suffer from cancer to services was limited. Being vulnerable, they were advised for shielding longer, which curtailed their physical activities, and on occasion there were delays to the cancer treatments, which presented a very unique challenge for the patients and for us providing care for around the patients. We at this point conducted a Delphi consensus looking at the global expert opinion on digitalization of prehabilitation. While 100% of all the service leads across the globe agreed that we needed to digitalize PREHAB, there wasn't much idea or consensus on how we should go about it, because no one had done this, and this was a very unique challenge that the pandemic had brought home to us. So we present our journey, which first and foremost meant coming together to form a website, making referral to our service, as well as engagement within the public and the healthcare professional groups easy to be able to refer and offer the service to everyone else.
Yeah, so when we started out obviously I was working initially face to face with the clients in the local satellite centres. So in local community gyms where bases helping taking them outside of that hospital environment. Once lockdown was coming into place, we quickly sort of took that transition of how we could go virtual and continue our sort of service to the patients. That was the main priority to us. As Dr. Rampol said, she completed the survey and we got sort of brilliant results back. So from there, we prepared our video and the nutritional information, so we had something to supply to the patients. And it was key to us. As I say, it was a way to allow us to continue with the patients we were already in contact with, so we weren't losing them. And then obviously it allowed us to take on the new patients despite the conditions and safely. There were some drawbacks we were a little bit worried about. Obviously not being face to face, it's harder to monitor people, get the response on how they're taking the training, if it's effective enough. So we had to make sure we stayed quite basic initially. And then as you're talking to them, we could change that sort of exercises as we were going and the level they were working at, etc. Obviously they were the drawbacks though, but we found sort of as we progressed there were so many benefits. Number one, it meant we could go from just providing to the Medway patients to the whole of Kent. It gave us access to everyone, which was key to sort of, we were sort of doing a minimum of 2 calls a week with our patients, some more if they needed that extra help. We would always arrange it around, and arranging it around their working schedule or their schedule was key as well. So some of them it has to be evenings, others you'll do a call on the weekend if they're busy. But that regular contact made a big difference to the patients because they felt like you were always there. It also, from our point of view, it meant that we could continue our treatment during the quarantine period. So for us, the virtual contact was also vital during the quarantine periods that was being applied to the patients prior to their surgery or treatment beginning. They were having to go into complete lockdown, which if we were face to face would have meant we had to stop 2 weeks early. So being able to continue virtually made a big difference. Also, the rapport you built by continuing.
Hello, yes, this has been a fantastic opportunity in a way, and after getting over the therapeutic challenges of offering telephone support, for example, unreliable technology, issues around confidentiality and privacy, and of course the vital clues around body language and facial expressions that are so important for the counselling process. We found some fantastic benefits, and in liaison with Roberto and James, we've provided a really rounded service, I believe. And of course, some of the benefits that James has spoken about have been, you know, the patients have been in the comfort of their own home. And once we have established some confidentiality and privacy and boundaries around the work, we've been able to get over some of those challenges. And a really big one is issues around transport and parking and payment for parking and having enough change. Of course, from home, all of those issues have faded into the background. And again, flexibility around time has been brilliant. We've had no missed appointments because we've been able to provide quite a bespoke service. Eventually, we were able to offer a choice of phone or online service. Some of the patients are gradually coming online. We've had more, we in actual fact have had more phone contacts. And of course, the accessibility, and if people are feeling unwell and not very able to get around, they haven't had to make an extra journey to come and find us. I think this has been, whilst it did provide a lot of challenge in the first place, I think we've found a really good and collaborative way of working together.
It's quite scary getting a cancer diagnosis and knowing that you're about to have major surgery, and I was quite nervous about what I could and couldn't do. Could I keep doing Pilates? Was it safe to run? what should I be eating? All of those questions James was able to answer and really kind of reassure me and encourage me, and basically talking to him, I knew I was doing the right thing, and that really motivated me to keep going and to sort of up those fitness levels where I could. Even though I was already quite confident and quite fit, the programme definitely increased my confidence at a really crucial time.
I was contacted a few days after my cancer diagnosis asking if I'd like to join the PREHAB programme. I said, yes, I'll do anything I can to beat this thing and get as fit as I can to deal with it. And I'm certainly very pleased that I joined. I've been very well supported during the whole thing.
So I'll definitely recommend it, because it's a very good programme and a very good crew.
So in here what we show is the map of Kent. As James said, that the moving to the virtual delivery allowed us to reach all across the county. So this is the map of the whole Kent, and we also have London, and we can see the distribution of the different referrals, where they are coming from. So we could actually reach all the different areas, starting from Medway. You can also find us now in the cancer care map, where we are listed as one of the services provided for cancer patients. We also wanted to assess the psychosocial impact of the intervention. So we measured different aspects like anxiety, depression, the loneliness the patients were going through, and the enjoyment of the physical activity. And we could actually prove that the virtual intervention that we were carrying out was as effective as the one we did face-to-face before COVID started.
So you've heard all about the programme, and a great team has been assembled to deliver a really positive experience for our patients. And the future is also bright, we feel, for PREHAB. We currently have a brilliant website, kentandmedwayprehab.org, where you can find out all about our programme. It also mentions our preprint sessions. These are sessions that are delivered to our patients in order to reach a wider audience, perhaps in groups. If you're a health professional, you can also come along and listen to those and see exactly what our programme entails. The future, as I say, is bright. We feel that the PREHAB programme sits very well in the Medway Public Health Directorate. That's a real unique feature to the programme, is that we are so closely linked with public health and the onward journey of our patients. We refer to it as PREHAB to rehab. So what we're trying to make sure we do is provide people with an onward journey in terms of health improvement, so that we're not wasting that opportunity that we have when people are in remission from cancer. We can link into many different public health services, such as quit smoking, alcohol moderation, our healthy weight programs, and general healthy lifestyle programs, which are so popular in the community.
The Cancer Alliance has been really pleased and proud to support and fund the PREHAB service, which we think exemplifies personalised care and support in the way that it delivers tailored interventions based on need to support patients as they get fit for cancer treatment. It's a service that feels very aligned with long-term plan recommendations and expectations in terms of improving patient experience, quality of life, improving health inequalities, and also very much, as mentioned, around that personalised care approach. And it's a very personable service. It's a very dynamic team that has already evolved from delivering in an acute hospital to moving out into the community, aligned with public health, adapted rapidly in the pandemic to deliver virtually. So we feel it's a really exciting service. We're really pleased to support it and are looking forward to seeing it develop further.
In a nutshell, it has been a very challenging time for the entire world and particular for the health and care sector. We are very grateful that we were able to be supported by Cancer Alliance and Public Health to help develop our service and make it accessible, make it flexible, and make it pandemic proof for the future. So these are the different ways that you can get in touch with us. We again thank the NHS Fab Academy for allowing us to present our intervention. And if you have any ideas, any suggestions, we look forward to collaborating with you. Thank you very much.
Shall we start with Dr. Ampel, please, to give us a summary, as we've only seen half of the video.
Hello, thank you. Thank you very much.
Good morning, welcome.
That's okay. That's the reason we presented the video. Morning. Thank you. The reason we put it all together was because between our clinical commitments, we weren't sure if we'll be able to attend. So thank you very much for inviting. And the reason for the video is to show that it takes a village. It takes, a whole team of allied health professionals, of clinicians, of patients as part of patient steering group to bring about any change that can be regarded as sustainable. Nobody wanted COVID-19 pandemic upon us, but it has led to some fabulous changes. And just yesterday, we were presenting at our local ICS groups and talking about how we have been able to break down digital barriers, geographical barriers through digitalization of this service. Whereas face-to-face attendance limited us within a certain postcode to be able to provide a service which consists of supervised exercise, kind of polypharmacy optimization, looking at patients' dietary requirements and nutritional optimization and counseling. But now that we've gone digital, we are in a luxurious position of actually accepting referrals from all over the county of Kent, a very populous and a very vast county. And for us, the patient feedback has been remarkable because we can now offer flexibility. When patients are diagnosed with cancer, the last thing they need is that they have to take days off to come attend sessions face-to-face for optimization of their functional capacity. So now we can offer them flexibility that they can fit in an hour session within their usual day-to-day living, and it's been a boon. So the video goes on further to explain the impact and links that we've got with Public Health, which is again an opportunity which was presented to us because we went digital, and the impact it has on patients. But our contact details are at the end of the video, and if anyone has any other interesting questions, comments, or suggestions, we're always looking for people to give us suggestions on how we can improve the service. Please do get in touch, and we'll be very happy to have a chat.
Thank you so much. And of course, for those who may not know, Dr. Ampel is a consultant anaesthetist as well as clinical director for PREHAB at Medway NHS Foundation Trust. So I always say you do two jobs in one. Any questions around PREHAB, first of all? Sandie, from the audience?
No, there doesn't seem to be any questions on PREHAB just yet.
Okay. Any other questions you have?
We have a question for Rena. Would you recommend CliniB as a tool for sharing guidance, and any tips related to that? Is Rena still with us? No.
It doesn't look like Rena is currently with us, I'm afraid.
Right. Okay. What I will do with anybody who is no longer on the call, I will collate the questions in one document, and we can maybe send out a question document afterwards when we get the answer.
Yes, that would be lovely, and we can put it on the website. Yeah.
And then we've got a question from James Hayward. Should review processes apply to all care home residents, not just those recently discharged from hospital? I would imagine that would also be to either Lely or to Rena.
Let me see, is Lely still here? No.
Right. In my area, that process does apply to all care home residents. So I can give an update on that. We do have a link between hospital and community pharmacy, so that is a synergistic transfer. Rena is here, but we can't seem to hear her. Oh.
I thought all the speakers, apart from Raliat, were going to stay. So I think they are here, but they may be having problems unmuting for some reason.
That's it. Rena's just said that her mic is on, so she
is in my she is here. Rena Mehta, Rena, are you able to start video? We can't hear her either. My mic is on, she says.
May help if you turn the video off. Video is on too.
Look, don't worry. Don't worry. Press on would be my advice. We've got about 12 minutes to go. So
so there is an offer of support to Lely from Jane Brightman, and would love to link up on the topic of integrated care.
Yeah, I know that's been dealt with. Lely has already contacted her, so that's good.
It's contacted, right? That's good. There was a question for me about discharge and delivery, not discharge, on delivery services. And just to let you know that what we have been advised is that the National Good SAM app is still available for volunteers. So a patient can request via the Good SAM app for either medicines or other food or any other delivery service, and get a volunteer who has been checked that can support them. We do also have a lot of our local authorities have a hub of volunteers, so local volunteers who have supported the process, and those hubs are still in place, and you should be able to find those hubs for volunteers on the local authority websites. And I think that is all of the questions we have had in the chat. Is there anything else anybody else would like to raise as a question?
John, did you enjoy the sessions?
I think you've all done an absolutely first-class job. You should be so proud of yourselves.
You know all about medicines now.
Well, look, multiple presentations from all sorts of different viewpoints and standpoints. I think you should all give yourselves the most colossal pat on the back, particularly you, Mojan. I know how desperately anxious you got about all this.
I hate technology. I knew technology would go wrong, and it did.
You are a complete professional. You've done a great job, and well done, Pip, as well. You know, he's done a sterling job just keeping everything in check. So, I think well done, everybody. You know, terrific job. I think one of the things to take out of this is, okay, so what are maybe the 5 key things that anybody who's been watching this, listening in, what are 5 key things that you could take away as things that you could go to your own organization with and say, there's something for me to give some consideration to? So that might be an interesting exercise. Or let's make it easy, given we've only got 9 minutes left. 3 key things that you've picked up. And I'm going to go to you, first of all, Mojan, and say, all right, so you've listened to all of that. You're obviously a professional in the space yourself. What are the 3 things that you would pick up that you think, you know, how about that for takeaway initiatives that could easily be replicated? Any thoughts?
I suppose putting me on the spot now, but I suppose one thing that's really close to my heart is the concept of unity. And listening to all those variety of presentations, and I suppose the COVID crisis, one positive thing that always struck me has been how we've moved forward in a united way within a multidisciplinary professional group and supported each other. And I suppose that was particularly striking from, well, all of the presentations, but certainly from Sandie's presentation in terms of pulling together, and also the care homes. A lot of the learnings has been around effective communications and how we can work together to achieve and manage a crisis. And I hope from the presentations, the learnings would help us with any COVID-2 if we are going to face that. So that's been quite critical for me. What else have I made notes? I certainly made notes.
If you don't mind me saying, Mojan, I think that's a fantastic observation, actually, that it's this united teamwork ethic, but it's not by accident. You know, that requires skill, it requires empathy, understanding, thoughtfulness, creativity. You know, these are skills that all of the presenters here have demonstrated individually and within their teams, and we shouldn't overlook how important that is. And I think it's instructive, unless I've missed something, with one exception. I think you're all female who made the presentations. And maybe there's quite seriously, maybe there's a lesson there in terms of an ability to listen intelligently and thoughtfully. And I, you know, Mrs. Wilkes would say the same thing to me, that, you know, men generally, they want to press on, they're impatient to get results, and maybe there is a distinct gender advantage there. I'm just throwing that out there.
John, we'd invited and actually advertised a fabulous presentation about medicines and digital technology. So Patrick Lynch from Cambridge was going to join us, but unfortunately he's been under a lot of pressure with various other roles. So you may have noticed we amended the program at the end. So we did have one male speaker.
That's okay. I'm not being entirely serious, but equally I'm not being entirely frivolous. That, you know, we should not underestimate the importance of the skills around how you unite a team to create the environment in which successful implementation of these initiatives can be delivered. It is a critical thing, and I think you were very sensible and astute to point that out.
Thank you. Sandie, did you have any last comments? I know there is something in the chat asking how people would access the recordings. John, do you know? I presume it'll be available from the website.
It'll be available on the Academy of Fab website and indeed elsewhere through different collaborators subsequent to today. There's, as you might imagine, there will be quite a significant editorial task to be performed to break everything up into small bite-sized chunks, but that should be, I'd say, within a week maximum, we'll be promoting the individual videos. Okay.
I think for me there's sorry, Mujkan. I think for me there are three key words that have come out from today, and everywhere that has had a success and everybody that has done some absolutely fantastic and amazing work, and it's three words, and it's communication, collaboration and consideration. And those three words for me sum up where success has happened, and that is what we need to continue moving forward.
Could you, I think that's really important. Just repeat those, Sandie, go on.
Communication, collaboration and consideration.
Love that. I think that was, you're already across the chat, we're getting a few people saying they concur with that. I think that's a fantastic way to end this, to be perfectly honest.
You can call it the 3 C's.
Oh God, here we go. We're going to have acronyms galore now. We can't go there. There's too many acronyms in health and social care as it is. Well, look,
so I just wanted to say thank you.
Well, if I may, on behalf of the Academy of Fabulous Stuff, Mojan, we owe you personally a huge debt of gratitude for pulling all of that together. You've done an absolutely superlative job. Thank you very much, additionally, to all of the speakers. If I try to go through them all now, I'm bound to miss the odd one out. So I'm just going to say, all of you who were presenting at this, you know who you are. You've all done a fantastic job. And I suggest you all go and get a very well-earned cup of tea now and a hobnob. And Pip, if you want to prepare for the next presentations in here, I think that's a fantastic.
Thank you, Pip, as well.
Thank you.